Elevated IOP alone does not fully explain the disease progression in all the patients. Vascular insufficiency and low ocular perfusion pressure are increasingly recognized as significant contributors to glaucomatous damage independent of IOP levels. Cup to disc ratio serves as a critical indicator of optic nerve damage severity and disease progression. Ocular perfusion pressure is defined as the difference between mean arterial pressure and intraocular pressure, representing an important determinant of ocular blood flow. Some of the landmark studies, including the Barbados Eye Study and Los Angeles Latino Eye Study, have demonstrated a significant association between low OPP and increased glaucoma risk. My objectives were to evaluate the correlation between the mean ocular perfusion pressure and cup to disc ratio in patients diagnosed with primary open angle glaucoma and to identify demographic and metabolic risk factors that may independently affect CDR measurements and contribute to glaucomatous optic nerve damage. My study design was a cross-sectional observational study among 93 patients with confirmed POAG diagnosis aged 40 years or older, and CDR was assessed via slit lamp biomicroscopy and fundus photography. IOP was measured using Goldman applanation tonometry. The vascular parameters of blood pressure was recorded in standardized conditions. Mean arterial pressure and mean ocular perfusion pressure was calculated using established formulas. Other risk factors like demographic factors like age and sex and metabolic conditions like diabetes and dyslipidemia was also analyzed as potential confounders. My key findings were the mean ocular perfusion pressure was found to be 47.52 and the mean CDR was 0.783, and the linear regression analysis confirmed MOPP as a significant predictor of CDR, suggesting that lower perfusion pressure is associated with greater optic nerve cupping. The scatter plot demonstrates the inverse relationship between the mean ocular perfusion pressure and the CDR. The negative correlation suggests that decreased ocular perfusion pressure may contribute to progressive optic nerve head remodeling and glaucomatous damage. So the clinical significance would be for every 1 millimeter mercury decrease in the ocular perfusion pressure, 0.005 unit increase in CDR is predicted, supporting the vascular hypothesis of the glaucoma pathogenesis. This model revealed a statistically significant negative association with mean ocular perfusion pressure, accounting for approximately 4.3% of the variance in CDR measurements. Also, multiple linear regression analysis was done to comprehensively understand the factors influencing the cupping. Multiple linear regression was conducted incorporating demographic and metabolic variables like age and sex, diabetes, and dyslipidemia. The key observations were the multivariate model revealed non-significant contributions from individual risk factors when analyzed together, suggesting complex interactions between the vascular, metabolic, and structural factors in the optic nerve remodeling. This finding highlights the multifactorial nature of POAG pathophysiology beyond the simple linear relationships. So the vascular contribution hypothesis provides a support for the vascular contribution to the glaucomatous optic nerve damage. The significant inverse correlation suggests that the compromised ocular blood flow may increase optic nerve susceptibility to structural damage, and the patients presenting with low OPP, even when the IOP remains within the normal or borderline ranges, may require more intensive monitoring and individualized treatment approaches. The multivariate non-significance observed in our regression model also suggests that optic nerve remodeling in POAG involves complex multifactorial mechanisms rather than simple independent risk factor contributions. This complexity may involve interactions between vascular, metabolic dysfunction, structural biomechanics, and genetic susceptibility that warrant further investigation. My findings were consistent with the existing literature of Barbados Eye Study, Los Angeles Latino Eye Study, and various Asian population cohorts. The limitations of my study were it was a cross-sectional design, therefore direct causation could not be established, and the longitudinal follow-up studies are required to determine if the low OPP precedes or results from the glaucomatous damage progression. Also, OCTA was not employed in my study, and hence measurements of peripapillary vessel density was not obtained, and other vascular comorbidities like migraine, nocturnal hypertension, systemic hypertension were not systematically assessed and may represent some unmeasured confounders. Also, sample size may be a larger sample size may be needed to eliminate the type 2 errors. So, to conclude, a significant inverse correlation was found between MOPP and CDR in my study, and lower OPP may increase the risk of optic nerve head damage. Systemic factors not independently predictive in this cohort, and the recommendation would be to incorporate ocular perfusion pressure evaluation also into the routine glaucoma workup, and longitudinal octa-based vascular studies are inevitable. These are my references. Thank you. Mean arterial pressure, sir, or
The perfusion pressure.
perfusion pressure was derived from the formula mean arterial pressure minus the intraocular pressure.
And what was the range, usual range which you saw?
Among the perfusion pressures, sir, 51 to 55.
Which is your highest and which is your lowest value?
57 was there, sir. Lowest 45. I'm not sure, sir.
So the 57 had severe progression. That is
Yes.
your argument.
Yes.
And that progression was taking how long a time?
So this was a cross-sectional study actually, and the patients within a duration of 5 years of diagnosis was taken as cases. So I'm not sure, from the study we could not make sure if it was preceding the glaucomatous optic damage or after the damage the OPP has reduced. That was a limitation of my studies.
Then the study design doesn't fit. You are trying to do something dynamic over a cross-sectional study.
Yes.
Over time, how much this pressure change, that is what your aim, stated aim is that you wanted to show that OPP, if it is increasing, it is inversely proportional. Try to do it prospectively with these variables.
Sure, sir.
Nice presentation, and as
you,
just
sir.
pointed out, there is a flaw in the methodology, but you can always improve that. And, did you correlate with visual outcome also?
No, sir.
So these are the other things, secondary outcome you can look into, whether perfusion pressure is impacting your IOP only, or even it is impacting your optic nerve head damage, like RNFL analysis or CT or field analysis. That will give more value to your study.
Okay.
Thank you.
Thank you, sir.